Join us as we commemorate National Doctors' Day on the birth anniversary of Dr. B.C. Roy, a visionary doctor to acknowledge and celebrate the invaluable contribution of doctors to humanity at large. TimesOfIndia.com is hosting a digital conclave titled National Doctors' Day, a tribute to the torchbearers of our health, bringing together doctors and even policymakers to acknowledge these frontline health warriors. I am Dr. Ananya Awasthi, who's the moderator for this session. As a quick introduction, I'm a public health practitioner with a master's in global health from Harvard University. My background is in policy consulting, and I currently lead an organization called Anuvad Solutions that works on translating science to inform policy action on India's health and nutrition agenda. Talking about the specific session, this session is based on the age of telemedicine. In recent times, as we know, the world has witnessed a significant shift in healthcare delivery, with telemedicine emerging as a powerful tool. Together, we gather to explore the comfort level of Indian doctors with this trend and discuss where to really draw the line. So join us as we engage in insightful discussions with experts in the field, exploring the merits as well as the demerits of teleconsultation, the challenges that may be faced by the doctors in adapting to this new medium, and the future of this transformative trend. We will also delve into strategies for maximizing the benefits of online consultation, especially in the Indian context. Now, going forward with the panelist introductions, we have today with us a beautiful panel starting with Dr. Sandeep Budhiraja with clinical experience in the field of internal medicine for the last 30 years. He's been working with Max Healthcare for the last 20 years. He is the Group Medical Director, Max Healthcare, and Senior Director and Head, Institute of Internal Medicine. He is Fellow American College of Physicians, Fellow of Royal College for Physicians at Edinburgh. Dr. Budhiraja is heading the Internal Medicine Training Program for MRCP UK. He's also received the Best Innovative Teaching Award, Vishesh Chikitsa Ratna Award, and the Krishnan National Teacher Award. Thank you, Dr. Budhiraja, for joining us. Then we have with us, thank you, sir. Then we have with us Dr. PBN Choudary, who has expertise in clinical protocols for post-discharge home care and health checks for insurance policy issues, integration of medical devices for remote monitoring and management, and design and development of SaaS modules. He is the PI for clinical studies during COVID-19. He took care of home isolation monitoring systems, protocols for isolation bays in communities, and diagnostic packages. He is responsible for implementation and maintenance of over 32 paperless electronic primary health centers in 2 states across the country. Dr. Choudary developed digital clinical management system, the DCMS 2.0, to run primary health centers digitally. Thank you, sir, for joining us. Then we have with us Dr. Kersi Chavda. He is the past president of the Bombay Psychiatry Society and is a consultant at Hinduja Healthcare, Sir H.N. Reliance Foundation Hospitals, and has also been the chairperson of the task force of the Indian Psychiatric Society, IPS, dealing with school psychiatry and counseling. Sir has been part of the group of Indian Association of Private Psychiatry that dealt with CallHealth Psychiatry. He is currently advisor of the IPS subcommittee dealing with mass media. He's been also part of the panel, the first panel by Maharashtra government that laid down concessions for learning disabilities in Mumbai. Thank you, Dr. Kersi, for joining us. And finally, we have with us Dr. Randhir. He is the chairman of the Institute of Digestive and Hepatobiliary Sciences, Medanta, the Medicity, Gurgaon. He is the recipient of Padma Shri by the President of India, is the past president of the Society of GI Endoscopy of India, is honorary fellow, Society of GI Endoscopy of India, fellow at the American Society of GI Endoscopy, fellow at Royal College of Physicians, Edinburgh, and also fellow at the International Academy of Medical Specialties. Thank you, Dr. Sood, for joining us today. So with that introductions, let's get started with the first basic question, and that's to you, Dr. Budhiraja, as a group medical director, looking at the larger picture. How prevalent really is telemedicine in India? And if you could also share some insights on whether or not COVID-19 itself gave a big push to teleconsultation. Dr. Budhiraja, please.
Yeah, so I would say that Indian telemedicine market was valued at $1.1 billion USD in 2022. And it is estimated, and these are certain business reports, and it's estimated to grow at a CAGR of almost 21% to reach a valuation of almost 5 billion USD by 2030. So that's just to give you financial figures of how this market in India is expected to grow over the next 7-8 years. Now, presently, there are a large number of players, both in public and private healthcare space, who have adopted telemedicine in a big way. Now, to name a few, of course, we have in government sector, we know the All India Institute of Medical Sciences has taken a lead in telemedicine. Amongst the private players, the bigger chains, whether that's Max, Apollo, Fortis, etc., have completely ventured into telemedicine. Then, players like Practo, 1mg, Clove Dental, and then the other part of the industry, that's the GE, Siemens, etc., Philips Healthcare, they have also sort of partnered in a very big way when we talk of telemedicine. So clearly, India in all sectors is deeply into telemedicine. But yes, the push has been given by COVID, the COVID pandemic. Prior to that, it's not that telemedicine was not there, but it was in a gray zone. Nobody was very clear about the pros and cons, the legal safety one would have using this platform. It was mainly restricted to certain rural, remote areas. A lot of government agencies were sort of working in it. The private players really ventured into it, I would say, at the inception of COVID. And as a part of COVID, I think telemedicine really has shown its worth, its value. We used extensively telemedicine for triaging COVID patients. It really offloaded the work out of the emergency and the ICU, because only those who needed to be in the hospital needed to be in these areas. Otherwise, we could manage these patients through home care as outpatient through the telemedicine consults. Even while within the hospitals, telemedicine played a big role in sort of monitoring and observing these patients. So one really did not have to go to the wards, and that physical encounter was markedly reduced, thereby helping patients get cross infections, and the healthcare staff, which was a very valued asset at that time, get this cross infection. So the world at large, the India, we all learned the benefits which telemedicine had and the potential of its use. And I think even after the pandemic is over, telemedicine retains its space. And in fact, I have given you the projections, the business projections, the way the industry is supposed to increase in the next few years. So I think we are very much there. India, as a country, adopted telemedicine, but there's, of course, a huge gap which still needs to be filled.
Right. Thank you. And interestingly, you mentioned legal and regulatory frameworks around telemedicine. We'll come to Dr. Choudary for answering that question. But before we get there, and thanks, Dr. Budhiraja, for setting the context of how real telemedicine is in India. My next question to you, Dr. Sood, what are the advantages for the doctors, the patients, and how does telemedicine really compare to the traditional in-person visits that we have in a clinical setting?
You see, I call informal telemedicine and formal telemedicine. Doctors have been engaging in informal telemedicine right from many years, maybe it's since the practice started and the telephones came in, because the patients ring you up to find out, to get a consultation. And this was, and then WhatsApp came, and so this was all informal. What has changed is a formalization of telemedicine, which has made it more organized. And there have been some effort, I'll not say wholehearted effort, on the part of government to put in certain regulatory in it, making doctors' position safe in prescription of medicine. You see, in a country like India, where patients have to travel from far off, particularly to reach a secondary tertiary care place or tertiary care doctor, it is significantly expensive. You will realize that our society, never a patient travels alone. It is the family who travels with the patient. So cost of travel of the patient, cost of stay of the family, and away from work, and just to take a consultation, a follow-up visit, which will last only 10 minutes. And so this becomes really expensive. And now we find that it is so useless to make patients come for a follow-up visit. The main advantage which I see of telemedicine is during a patient whom I have seen, who have prescribed medicine, and needs to come to show me the reports, needs to come to take guidance about continuation of medicine. That's where I can contribute the most. But a patient who has never seen me and is coming for the first time, there the problem is that I cannot really diagnose the patient totally. That's, I call it a facilitatory visit. That the patient tells me what the problems are, I can tell me what are the possibilities and how much cost it will be, so that the patient comes prepared. So that's where the telemedicine rests today. It has a tremendous advantage both to the doctor as well as the patient, because doctors can optimize their time and can see patients. The patients have in fact a huge advantage. They don't have to disrupt their daily routine. They do not have to disrupt their work, and the whole family doesn't have to travel with the patient, and that can be, they spend the same time in the sitting in the comfort of their homes and getting a consultation done.
Right. And we'll talk a little later, talk more about how this might be most beneficial in an Indian setting where resources are constrained. And as you said, it's not a single patient that travels, it's the entire family that will travel, and that can mean a lot. For say even daily wage workers and so on and so forth. Talking of a legal or a regulatory framework, Dr. Choudary, what does that look like in the country, and what more needs to be done there?
From the legal perspective, right, as I totally concur with what Dr. Sood earlier said, and Dr. Budhiraja, how the telemedicine has opened up pre-pandemic and post-pandemic. Well, Government of India has published couple of guidelines, right? So one thing which I would definitely recommend all the doctors who are coming to field of telemedicine with the technology evolving is go to certain documents which are already published. For example, telemedicine practice guidelines were published in somewhere March 2020. Then we had electronic health record standards for India that was also published by 2016. And then there's a IMC, which is now NMC now, which has earlier published etiquette and conduct regulation of 2002, and now National Medical Commission has a draft of how about a professional conduct for a registered medical practitioner. So there are certain documents which are available, and I would highly recommend. Being a doctor, to be very honest, our entire focus is on the treating the patient. There's a regulatory framework as well as a treatment part, right? Most of the people who are exposed to technology, they will understand the importance of regulatory part, because now with the privacy concept coming in, as said by Dr. Sood, health in India unfortunately is not individual, it is a family concept. So if one person is sick, the entire family is going to talk about the conversation. And unfortunately, as doctors also, we tend to talk about the patient details. One thing which I strongly recommend, and which I've been telling in multiple cases wherever I go, is when you're talking or discussing a case, do not reveal the patient identity unless he's a treating physician or the doctor is a member of the team who is treating. Generally, what happens is, as a habit, doctors do have a conversation with their colleagues. They will say, "Acha, maine se baat kiya." You can have the conversation, but do not reveal the identity of the patient, because somewhere down the line, the regulatories are going to be very tight, and that is something going to be a pain point. So that is one part. The second part is that the doctors have to be well versed in using the software for telemedicine. What happens is, for example, if I'm using a particular software, and the software would be designed, majority of the platforms who have software, for example, as Dr. Budhiraja was saying, Apollo's, CallHealth, or any other multiple platforms which are there, they will take into consideration all the regulatory framework required to protect the doctor as well as protect the organization itself. The place where doctors fail is that they do not fill in all the forms which are there in the electronic medical record. What I've seen is we generally just add in the symptoms, and we just do not key in the details required for the history of the patient. We directly go into the prescription part. So what happens if God forbid something goes wrong, there's nothing for us to fall back on the documentation part, because we just have the symptom and the prescription part. So from the regulatory point of view, the documents are available. It is more of this, just the understanding or acknowledging that the privacy is a major concern that is going to come in the near future. Part two being is, as I said, right, health is something we generally discuss as we discuss any other points for discussion. Maybe that we should have some kind of what is the word which I would use is control. I'm not very sure is the correct word to use on that, but when we are having conversation with other doctors, let us make sure that we do not identify that patient unless he's a treating physician.
Right. And again, we'll come to patient data and concerns around that as well, since that's also an evolving field. We've spoken about what it is from a doctor's perspective, but coming to you, Dr. Kersi, with your long years of experience, you've dealt with cases around psychological well-being of patients. Have you noticed any differences in patient satisfaction or compliance with treatment plans between those who are seeking teleconsultations vis-a-vis those patients who are taking in-person consultations? How is that different?
Well, I don't think that there's any doubt about the fact that face-to-face consults are much better. I mean, the old traditional doctor who would, be across the table, talk to you, maybe pat your hand once in a while, maybe give you an injection, do the blood pressure, do the pulse rate, and all of that is not possible when you're doing teleconsultation. Teleconsultation, however, given the fact that if I'm in the field that I am, psychiatry, which has probably the least number of consultants amongst all the other consultations in India, I think we have hardly about 10,000 psychiatrists in the whole of India. Given the fact that we have more than 1 billion population, that's a huge amount of people who need access and don't have access. Given all of that, we've always had things like, you had a suicide helpline which was run by the Samaritans. That in a sense was a kind of a teleconsult. You had a lot of states had their own drug consults. So if you were a drug addict and you wanted help, you could always call up somebody and then they would tell you what to do. Like one of the previous panelists said, things got extremely formalized after COVID, when it suddenly became impossible for people to travel. And when they found it impossible to travel, then they still needed access to medication, they needed access to doctors, they needed access to getting better, they needed access to the new problems that were coming around. And when all of this happened, the government fortunately came out with a whole bunch of guidelines related to what teleconsults were allowed to do and were not allowed to do. Given all of that, now that COVID is over, there are still a huge number of people who would prefer teleconsultation. Why would they prefer teleconsultation? Somebody has also said transport is a big thing. Somebody has said that you travel with your family, so it becomes fairly expensive. If they had a choice, I have no doubt they'd prefer to see me face-to-face, frankly. But if, for example, I'm in Mumbai, and in Mumbai to travel from point A to point B sometimes takes you 45 minutes, 1 hour. And if the person can save that going up and down and he prefers a teleconsult instead, he would choose that. There are limitations. There's no question about the fact that there are limitations, but it certainly has its own advantages.
Right. Talking about limitations then, Dr. Sood, in your own practice, would you like to identify some of these challenges, limitations, and also in the context of where should the doctor know how to draw the line on whether or not teleconsultation may in fact be the right choice to make there?
See, we must understand that teleconsult is not necessarily the end of a consultation, because a patient contacts you with a problem, sends you the data of or the investigations which you can order, and so you assess then whether you have got enough information and patient is stable and just needs to be continued on a medicine or just tweaking of the medicine, and do you need to see the patient physically, because I deal with, say, patients with liver disease, I deal with patients with the inflammatory bowel disease or pancreatic problems. So I need to look at the patient, I need to feel the abdomen of the patient, or I need to really assess the patient physically. Then I tell them that this is you do till you come to me, but you need to come to me as soon as possible. So I think this requires a very smart thinking on the side of the doctor to decide which patient can be dealt with just telemedicine, or which patient can be given that advice to come physically to the hospital, so that but let me tell you, the maximum advantage to patients are those, say, the patient was admitted with me and now has got discharged, and I need to see his blood tests after a week, and I have already evaluated him in detail. Then the patient sends me his reports, then talks to me and tells me the stability, and you have preset parameters which you have told the patient, him or her, to monitor, and then you go by that and you are satisfied, then you can save a visit. And similarly, a stable patient on a chronic disease where the patient just needs to come periodically to get a checkup and tell you the symptoms, show you the reports, but you don't have necessarily to examine anything in that patient, then you can easily follow this patient for telemedicine. But then there are patients with the various other disorders where you need to see the patient, you need to physically examine, and I think that is the biggest limitation in doctors trying to decide which patient needs to come physically.
Right. I have a follow-up question here. Suppose clinically you have understood that this patient or this situation does not call for a teleconsultation and would actually require physical examination.
Right.
How would you typically communicate this to a patient who may be wanting to do a teleconsultation, but how do you communicate this nuance to a patient or their family?
See, it is not very difficult. The patients are continuing to follow you because they have faith in you. You have treated them. And if you tell them that, no, sorry, you need to come, otherwise you may get into a complication, and and you can still save their time by telling them that get this test done before you come to me, so that instead of staying outstation for 2 days, they can go back the same day after you have examined. So you have not wasted a teleconsultation, you have added value to it, and you can easily tell them that what are you coming in for. Whether you need to plan for a admission, whether you need to plan for additional day stay in a different place, so that all can be communicated to the patient.
Right.
I'm going to intervene over here if you don't mind, because this happens to us a lot. Unfortunately, the general trend of thinking is that psychiatrists don't touch their patients. They only talk, which is a whole bunch of crap, with due respect. So basically what we are looking at is, we are talking to a patient, and if over the teleconsult, we feel that the person needs to be seen in person. He may be from another city. Now, I have a whole bunch of people calling me from various cities through the hospital teleconsult line and things like that, where we have video consults all incorporated with privacy concerns taken care of. In such a situation, it is mandatory upon me to tell that person that, look, I don't think you should be seeing me on a teleconsult. I think I will not be doing the right thing by you. You need to go to the nearest ER in your hospital. If you have a problem with finding somebody, I'll be happy to give it to you, give the person's name to you. You are not a case which is conducive to a teleconsult. You need to be seen physically. And there have been, even during COVID, when it was so very difficult for people to travel, there have been times when I have put my foot down, and quite correctly, because afterwards the patient would call me and say, yes, I had to be admitted. Yes, this happened. Yes, I had much more than what we thought we had. The Indian patient is not a nitwit. He would listen to the doctor, and he would kind of accept that if the doctor is not willing to see him across a video, there must be a reason for that. And he will probably take the advice that is proffered to him.
Right. So true. Then again, building on that, on the flip side, suppose it is, Dr. Kersi, suppose it is a case of teleconsultation, and of course you're the expert on non-verbal cues, and communication is more than just talking on a virtual platform. So in a teleconsultation, and maybe for doctors who are coming from your field and who are watching this, or for other clinicians as well, how can doctors establish a strong doctor-patient relationship in a virtual setting, given you're not physically sitting across the table?
Okay, so we start off with the premise that the person needs to see the doctor. Otherwise, he wouldn't have taken the trouble of making an appointment, taking the trouble sometimes of finding an internet connection in a place where internet connections may not be so good, and then calling you and then giving you his history. So he's, unlike in a place where a person is dragged to a doctor, here he voluntarily calls you and he asks for help. So we're already working at an advantage. Yes, if he were opposite me, there would be certain cues I would look at, certain cues he would look at. He would find me smiling, he would find me maybe laughing at times, or cracking jokes, if he was crying, I might be able to pat him and say, don't worry, or something of the sort, depending on what the situation is. All of that doesn't happen across a screen. But it is not so difficult to somehow convey to a person that you care. And you care not in terms of sympathy, but you care in terms of the fact that you're very sorry that he's passing through what he's passing through. So to say things like, oh my God, I'm so sorry this happened to you, is not very difficult to say. To say something like, that must have been quite traumatic for you. I can imagine that you went through a very bad deal, or stuff like that. Over a period of time, we learn how to say things. And the most important thing over here is to make yourself the subject of the sentence. So it's not, you must have been very, very traumatized. It's, I feel bad that you went through this. So when you start talking about yourself, that in a sense conveys empathy for all the other doctors listening. And also, the important thing is that somehow we've got to tell the other guy that I'll never be in your position, which I won't, but I can to some extent commiserate with what you're going through, understand the feelings that you're experiencing, and I'll do my best to ensure that we'll reach somewhere in alleviating the suffering that you are experiencing.
Great. What a wonderful tip, and I'm sure it should apply to all the specialities as teleconsultation grows. Coming back to Dr. Budhiraja, you gave us the big picture in terms of how big this telemedicine industry is in the country. Talking of economics, what do you think about the potential that telemedicine has in terms of reducing costs for healthcare, especially for rural populations in a country that is geographically as big and diverse as ours?
So I think the obvious answer to that question is yes, it has huge potential to reduce healthcare costs, and more so in rural areas. But to substantiate that answer, and in fact, there was a study which was conducted in 2020, specifically to understand the health economics which go around the telemedicine. And what they study, and this was from Southeast Asia somewhere, and they clearly found that telemedicine reduced the healthcare costs by as much as 56% and lowered the travel costs by 94% when doctors used telemedicine. And in this particular study, they restricted the study patients to few departments like critical care, pediatrics, dermatology, and radiology. So I think the same study could be sort of extended to all other specialities. And clearly, I see a huge economic burden coming down on the patients. Now, and when we talk of rural areas, one must understand that presently the way the Indian setup is, our smaller cities, towns, rural areas generally have smaller hospitals, district hospitals or clinics, where at best what they do is secondary specialties, secondary care, and generally at a rural level, primary care. Now, and it's not that ailments which are to be managed by super specialties do not happen there. They do happen, but somehow it's the GP or the family physician who manages it. Now, imagine a situation that I want to increase the scope of these district hospitals in rural areas, in smaller cities. There are only two ways. One is I can get to my specialist to go there, work there, or at least do some clinics. Logistically, economically, it will be a big burden on whoever is the payer, whether it's a government or an individual or insurance. A same situation where a person sitting in these remote areas is able to access super specialists is through telemedicine. The same infrastructure in their district hospital or the clinic, all you need to do is have an internet connection and a GP who assists this teleconsult as a mediator. The doctor, the super specialist or the specialist sitting in a bigger cities to which these rural areas are attached to in a hub and spoke model can actually deliver nearly a good quality clinical decision. At least he can tell, look, this is what you need, this is the treatment, or at least, no, you are sick enough, you need to come and travel. So then only those patients who are that sick, then you need to travel rather than everybody needing to travel. So clearly in rural areas, especially if you're talking about, I see a huge advantage. Now, just to quote one more study, this was a study done in US where they found that there was a 63 times increased uptake of telemedicine in rural areas post the COVID pandemic. But surprisingly, there was yet another study from Australia which actually failed to show any economic benefits in terms of hard cash saved, but definitely it improved the logistics and the time saved in transport. But in our country, I think this model, at least for smaller cities, towns, and rural areas, does make a lot of sense. Where the distances are too much, the connectivity is not so good. All you need is internet connection, which I think the present the way is internet is going into each and every village area, and with the 5G technology, I think that's a boom for the telemedicine. So I think clearly in all respects, it makes a lot of sense.
Right. On the same lines, Dr. Choudary, you've been working with the digital or digitization of primary health centers in the Indian setting. Would you like to add something more in terms of the benefits that you've seen through your own work and research in this area, and maybe some challenges here, or some assumptions that you think we are overstretching certain assumptions in terms of, say, digital connectivity or any other related aspects?
No, I think regarding the digital connectivity, we are in a much better situation compared to the previous decade. So coming to the clinics, what I had established was a couple of years earlier, where we were running the entire primary healthcare for government of 2 states, and then we were running for them. So the one thing which was earlier pre-pandemic, or let us say in 2000 or late 2000, was that there were a lot of resistance that was there towards the telemedicine. So telemedicine is something which I had very seriously, which I have a lot of belief in, and then subsequently patients to realize the advantage of having telemedicine. So they do not have to come to the primary center. Let us see, my conversation right now I'm restricting to primary health. So even in primary healthcare, people do come away from far away places. Now with the help of telemedicine, they were used to connect using a smartphone. And surprisingly, generally we say that people below poverty line or a certain sector do not have smartphone, but surprisingly most of them do have smartphones. So most of the connectivity used to happen through telemedicine, and a lot of times it used to happen is that the patient used to come to the primary healthcare center for the consultation, but they never used to wait for the physical consultation. They used to say that I would like to have a teleconsultation with a doctor. One, that is, there was additional doctors who were available to consult through telemedicine. Number 2, the doctors were accessible. Number 3, the turnaround time, wait time has been reduced drastically. And there are certain conditions where the doctor used to do for teleconsultation. Otherwise, if the doctor felt that the consultation would be requiring a physical consultation with the doctor, we used to refer him to the doctor, as Dr. Su, Dr. Chavda, and it is up to the doctor to decide whether the consultation has to be there to a physical consultation, that's one-to-one interaction, or it has to be virtual. And that decision is primary, something which is very important, because that is somewhere down the line is going to help the doctor. And sometimes what it does happen that a patient demands teleconsultation, but the doctor has to say it is not feasible, you have to get a physical test done. So in that manner, teleconsultation has been very well adapted. The technology, as you see, thanks to the Prime Minister and all the digital things which are coming, the UK is the best example right now. With the UPI coming in payment, initially it was difficult to make multiple payments and you have to have multiple apps. Now it's one app which is taking care. So the consumption of digital media has gone up. The acceptance of digital media, I mean, when I say media, it is not the entertainment part, what I'm talking about, I'm talking about the communication channels. And there are multiple digital platforms which are available. So from that perspective, I do see that teleconsultation is the way forward for the conditions where there are clear-cut guidelines, or for example, for a review consultation, post-surgery follow-up. You have nowadays, you've got a lot of equipments which are there, for example, for dermatology, ophthalmology, there are multiple equipments which are there. If they are integrated in a solution, you can use those equipments to find out the status of the patient condition and then take a call.
Right. Coming back to Dr. Kersi, for the viewers, could you give us some live examples? Maybe share, of course, anonymized examples, but share with us some examples of where teleconsultation has actually, boom.
So this is my
has been taken.
favorite example. During COVID, I actually was instrumental in setting up 5 helpline centers in Mumbai. 2 of them were for the entire nation, and one was specifically I was asked to set up something for the LGBTQ community because they have their own individual problematic areas and they were in a very bad shape. One pharmacy, a very big national pharmacy asked me to set it up. And the Bombay Psychiatric Society set up their own helpline service for people in distress. But my favorite anecdote is this. I was called by a person from a small village in one of the very poor states in India. I'm not going to mention the state. And he described what was, we had this thing because we were kind of, it was set up by a kind of semi-government, semi-other thing. The thing was going through into small little areas even of India. And one of the guys came across an advertisement and he called me. And when he called me, he described what was happening to him. It was actually something like what we would call a panic attack. He was getting into a panic. He was palpitating. He was getting breathless. His hands were trembling. He was feeling he was going to vomit, etc., etc., etc. And we went through the entire history. And I told him that he needed some medication. Now, the government has also laid down guidelines as to what medications you can prescribe online and what you cannot, quite correctly. So when I told him about it, he told me that there was no doctor in the vicinity. He would have to walk an hour to reach a chemist shop. And he says, I will call you from there and you talk to the chemist and you tell him what I should take. Now, those were the very, very busy days where we were getting inundated with calls where everybody was in a very bad shape, looking at the way our news readers were screaming and shouting. You kind of got a heart attack just watching them. So when I waited, and after about an hour and a half, he actually called me back again. And he told me that he had reached that chemist. I spoke to the chemist. I sent him, you're allowed to send digital prescriptions. I told him what he should give. He didn't have that particular brand, but he had something very similar. He told me he would give it to the guy, and the guy took it. About 2 weeks later, that fellow called me back and he said he's never been as happy as he has been at that time. His panic had stopped totally. He was really very thankful, and I'll never forget, he told me, Saab, agar aap kabhi bhi idhar aaye, तो हमारे घर में आके चाय और नाश्ता जरूर कीजिएगा. और that is the reality of India. And it is so sweet. It was so beautiful. That is something that really touched my heart. I had another one where there was this guy who had, who was actually speaking on behalf of his father, who apparently had a stroke some time ago. And because he had a stroke, he could not speak properly. So his caring son was doing the talking. The father was in the background. And I was telling him what to do and what to look out for and to give me his pulse. And that time everybody had that app. So everybody was checking blood pressure and oxygen and this, that, and the other. And we took his history. And then I told the guy that I actually felt that the fellow was going into depression, that the old man was going into depression and stuff like that. And I suggested what should be done. We started the medication and, we had a follow-up after about, I think, 3 weeks. And after 3 weeks, that man told me that his father was much, much better. He was sleeping better, smiling after ages and so on and so forth. And through, the guy couldn't speak. So, and he couldn't even write because he had lost the ability to use that particular hand with which he used to write. So he would somehow mouth things and attempt to make the person and to make his son understand what he was trying to say, which was very difficult, but he was managing. And apparently he told that son, this doc's a good guy. Wasn't that lovely? It was beautiful. More important, he did well. More important, after a while, when COVID got over, they came and they met me physically. Now, it's a good thing for a person, even if you're on telecommunication, to at regular intervals, do an actual face-to-face consult. However good you might be on a telecommunication video, there are certain things you might miss out on. And given the fact that we don't want to miss out on anything, it would be a nice thing if the person would come at regular intervals, which they do now. Everybody now has started coming. There's still a lot of people who prefer commuting. Like if I'm practicing in Bandra and in Mumbai, and the person is in New Bombay, he might say, can't I do 2 telecommunications and then I'll come the third time? And if you know what the person is going through and you've already seen the person and you've examined the person and you evaluated the guy and know more or less what to expect, that should not be too bad a thing. But there are times when we actually tell the person, no, I'm not going to see you on video call. You have to come and see me now. COVID is over. And then they may grumble and they may say, but please, and it's allowed, and send us a prescription. There are times we have to say.
Right. And Dr. Sood, you also spoke about this. So some more insights on how does a clinician, how can they strike a balance between, teleconsultation vis-a-vis physical consultation, and maybe some message that you may have for potential, I hope everybody keeps healthy, but for potential patients who may in future may be given a choice to have a teleconsultation. What would be your message to the clinician and to a potential patient in this context?
As I told you, the most useful area of teleconsultation for my patients is when they are follow-up patients. Because you know the patient, you have analyzed the patient's disease, and you know what are you looking for and what are the red flag signs in that patient. But the difficult situation is a new consulting patient who rings you up with a problem, and the patient is unable to describe that in detail, and we are dealing with the sicker patients. And in that, you don't want to miss on signs. After all, you can list the patient, but you need to see the patient, examine the patient to decipher the disease and the severity of the disease properly. And it is only after that you order tests. Otherwise, what happens is that at times you order too many tests beforehand, and the patient ends up spending too much of money. And that when he or she comes to you physically, you feel that if you had examined the patient, maybe all this would have been useless. So first consultation, I always say, where I have never seen a patient, is a facilitatory consultation. That I try to assess the patient's needs, tell them what they need to plan for, whether they need to come and visit physically, whether they can go to a nearby physician and make the physician talk to me, and it is I can facilitate their treatment through my insights into the disease through another doctor, as Dr. Budhiraja was saying, that holding hands of a secondary care physician and telling them how to treat or how to optimize the treatment of the patient. Or if a patient needs to come to a tertiary care, then we can tell them that how much the cost is involved if there's a pre-diagnosed condition, and how much time it will take for a particular procedure, how many days they should plan to stay. So they are already prepared. Otherwise, in India, it's not only the problem of the patient's condition, it's also financial problem. That patient has to end up paying the hospital, they don't know how much it's going to cost. If all this information can be given to the patient beforehand, this facilitates their subsequent care a lot. So in my view, the most important thing for a patient who's seeking the first time consultation is not to expect the doctor to treat him or her in totality, but it may be the first insight into the disease. The bigger problem in the first consultation we also feel is prescribing certain group of medicine. I think that Dr. Kersi has been fortunate. He could prescribe psychiatric medicines to these patients, which unfortunately the government of India does not let you do it, because you cannot, unless they are follow-up patients, you cannot give them certain group of medicines. So your hands are bound. And also, if there is God forbid, there is a complication of the treatment which you assume, then you have to share the responsibility. So I think the first consultation, where you have never seen the patient, cannot be a complete consultation. It is a facilitatory consultation. Follow-up consultation is no problem. There you can help the patient the most.
Dr. Choudary, some final thoughts on the ethical framework, data privacy, those concerns, and how do we need to be careful around this, and if there are certain gray areas that still need greater action by the government or by clinicians or the private sector alike?
From the perspective of, let us say, from the technology with the privacy, the ethical part, all the things which are coming, I think the most important part would be is that during the teleconsultation point, consent is one critical component which needs to be very well spoken about. The doctor has to educate converse with the patient, build a relation, and then subsequently down the line put the word across, saying that the data, whatever is being captured, is being digitally recorded. Number one. Number two being is the consent. Number three is one of the things what doctors can do to be on the safer side is that do not use the data without the patient's permission, saying that for a presentation, for let us say a conference, you're taking a photograph, make sure that there is some kind of consent for that. Most of the solutions that are there and available in the market, majority have inbuilt consent. But what happens is, in practice, what I have seen is, even though it is like you're in emergency department, you have got everything available, you got a book which says emergency, you say step 1, 2, 3, 4, 5. But then what happens, sometimes the person is supposed to read the book, does not read the book. In a similar manner, there are a lot of checks and balances which are built into the solutions nowadays, where the regulatory compliance is taken care and then you are safeguarded. But the problem here is, what I've seen is the doctor missed that part. As I said earlier, right, we as doctors, we have a habit of writing point 1, point 2, and then we go for the entire prescription part, the focus on prescription part. Now that is slowly changing, but there are a lot of, it has to further change. So the electronic health record, that is going to be the critical part which is going to happen. And one other thing, what I have seen and which is going to lead to an issue is that there is a sharing of credentials. Sometimes the doctor gives a credential, a junior doctor goes and does the consultation part. But God forbid something goes wrong, and it is the credential of the primary physician who will be liable for that. So they're non-sharing. And one of the other things which I have recently seen and I've read, that when there's a teleconsultation going on, most of the time it is in the hospital environment on the time, or that working hour, that is fine. But sometimes I've seen people actually taking consultations in malls, in cinema theaters, in public places, even if it's a small consult. But what happens is the privacy part is lost. So from that point of view, I would definitely say that most of the things are already built into the solution. So it becomes very important for the doctor. If it is a hospital anyway will invest into a hospital management information system. But if it's an independent clinic or small clinic, it is imperative that they go to a vendor, or they evaluate multiple vendors and platforms which have the guidelines built into it. Maybe they might have a security protocols of, maybe they have ISO 27001 certificate, or they have some HIPAA guidelines, or where the data is stored. So there's certain little bit of dig up should be done from the individual practices, because the hospital will anyway, to protect itself legally, will do all the checking before taking the software.
Right. With that, we come to the end of this session. I hope the viewers learned a lot, because I personally learned a lot through this session. And let me conclude by saying that telemedicine, as you saw and as you learned, indeed brings convenience, accessibility, and efficiency to healthcare, allowing patients to receive medical guidance from the comfort of their homes. However, it is crucial to examine the boundaries and limitations of this approach to ensure patient safety and quality of care. Thank you so much. Bye for now.